Hey, what's going on, nerds? Welcome back to the channel for another Otis tutorial for audiology students. And because my license expires tomorrow, I am going to record as many videos as possible for today, just before it expires. Okay, so today we're going to do self-test level 6, because last time I did level 5 and it was the patient name was Julia. Today we have level 6 and the test subject name is Kevin. Okay, so let's check out what's going on with Kevin. First thing, we need to check on the information on the subject. So Kevin is 72 years old, has suffered from Meniere's disease, left side with attacks of giddiness. Okay, so one of the symptoms of Meniere's disease is vertigo or dizziness. So that's reasonable here. And then, And then the case history. So hearing deterioration, left ear with giddy attacks for years. Recently, hearing impaired through hearing deterioration in the right ear. So the right ear hearing is going down as well. Also, by the way, from the case history, we can not like predict, but can have a very, very general picture of the patient's situation, like Meniere's disease. So like Meniere's disease normally or usually it affects the low frequency hearing first, and the reason or one of the reasons is that one of the reasons that's caused that causes the Meniere's disease is the what we call endolymphatic hydrops, meaning there will be over influx or less draining of the endolymph in the scala media. And so like the scala media will be ballooning, so it will push downward, or like graphically it will push downward the basal membrane. And the property of the basal membrane is that it's more it's floppier at the apical end and it's stiffer in the basal end. So the apical end of the basal membrane is more prone to be broken due to the, let's say, physical trauma, or the ballooning of the scala media because of the pressure that's exerted on the basal membrane from the endolymph. So the apical end of the basal membrane is more prone to be broken. And as we know, the apical end of basal membrane is in charge of the low frequency hearings, and the basal end of the basal membrane is in charge of the high frequency hearing. So that is why, or that's one of the reasons why Meniere's disease affects the low frequency hearing first. But the hearing will be fluctuating as the symptom gets more severe, and eventually all frequencies will be affected. It's just a little prediction, but because we don't fully understand the reason of or the cause of Meniere's disease, that's just one of the explanations. But anyway, let's go back to the patient. All right, so we'll just ask which ear is better ear. So Kevin says hearing is better in the right ear. You can say, we can see there's the red symbol here. And we'll click on the otoscopy. We'll check on the otoscopy. I would say the left, both ears are normal. Some might say it's a little bit retracted here, but it's not. It could happen in some people that you might think it's retracted, but it's actually not, because if you Google retraction of TM, then you see they're really, really, really retracted. And also, I think the otoscopy here is the same as Julia or many other patients here on Otis, because they just CVF to take more pictures. But anyway, So otoscopy is normal. So next step, we're gonna do the tuning fork. First, we do the Weber test. So the test subject, here's the tuning fork on the right. So the Weber test, it means you will ding the tuning fork and place it, the handle part, on the middle of the patient's forehead, and ask the patient which side does he or she hear better or louder. Then if the Weber test, if the Weber tuning fork is lateralized to the better ear, that means the that means the worst ear is either sensory neural, or just, it's most likely to be sensory neural, but it's not decisive. So we can't really rely on the tuning forks because it does have some I don't know, fail rate. Okay, let's try the Rini test. So the Rini test is positive for the right ear and negative for the left ear. Positive Rini means the sound or the signal is perceived louder through the AC pathway than the BC pathway. So if it's positive, that means it's either normal or sensory neural, like it's less likely to have conductive component. If it's negative, that means the BC pathway is conducting the sound better than the AC pathway. That means there might be a conductive component. As I said, it's not 100% accurate. We can't really rely on the tuning fork tests. But anyway, it's just part of the test battery, and it's just good for cross-checking. Anyway, let's move on. All right, as the patient mentioned that the hearing is better in the right ear, so we'll probably start with the right ear. Okay. Now, since it's the third or fourth, it's the fourth video, and then I'm pretty sure everyone's pretty confident with the Houston-Westlake technique. So I'll keep quiet for a while. Okay, that's our first ascending. Again, we need to try to make sure we're not being rhythmic in real life, but here I do not give a hoot. I do, just not as much. So see, every time if there's no response, I tend to increase the signal to like 20 to 30 dB, just to save some time. It doesn't really matter if you're just increasing 10 dB increment or 20 or 30 or 20 is like, I don't know, more textbooks. Oh, what am I doing? Okay. Wait, what? Okay, yeah, right. Okay, that is our first ascending. It's our first ascending of 55 dB. So we had first ascending for both 50 and 55. Okay, that was our second ascending for 50 dB. All right, so because there's more than 20 dB interfrequency gap, I would say, so we will have to test 1.5K, the interoctave frequency. That's our first ascending. That is our second ascending. I'm not very sure about 2K. Yeah. Okay. Yeah, that's about 50, 55 not too concerned. So let's move on to 4K. You sure right ear is your better ear? Wow. So that's what we call probably a dead ear or dead region. Okay. Because there's more than 20 dB gap, we have to test 3K as well. Okay, was that our first or second ascending? I can't remember. I'll do it again. Yeah, okay. So I'm pretty sure there will be nothing 6K nor 8K. Okay, yeah, there's nothing. So if there's nothing, we just save as not heard. Because of maximum output, it's allowed here is 110 dB. So you want to extend the range to go all the way down. That's what I do. I would go all the way down because it's not a real person. Well, if it's real person, you probably wouldn't. Okay, so we go back to 1K and we retest 1K just to make sure our patient knows what he is doing or what we are doing here. That was our first ascending. And that was our second ascending. Okay, let's just save it. Let's move on to 500 Hertz. Was that first or second ascending? Oh my God. My brain is not functioning at this moment because of the coronavirus. Not that I have coronavirus, but you know, the isolation and quarantine thing is making me crazy. Now, speaking of the quarantine, the only social event that's happened to me these days was that I greeted some strangers from Overwatch, which is an online video game. My life has been good. Anyway, okay, we got 250 Hertz. Now let's move on to the left ear. So I'm expecting the left ear will be super bad. All right, to switch to the left ear, you'll either click here or you click smash the L. That's the shortcut for the left ear. I'll start with 60 probably. Yeah, as I expected, there's no response. 70, let's move back to 60. So 65 would be our first ascending. We'll go back to 55. Oh, that was too loud. Okay, that was our second ascending. So in the clinic setting, you probably wouldn't want to smash your key so loudly. The patient would probably hear that first instead of the signal. But I would say Kevin is pretty deaf, so I'll smash it as loud as I want. Again, I blame coronavirus. It's nothing. I just go oof. Okay, our first ascending is 95 dB. Yep, that was our second ascending. Because there's more than 20 dB gap, we have to test 1.5K. I'll start with 90. Our first ascending should be at 80. Yes. Please give me some response. There you go. Okay, 1.5K. Now we move on to 4K. I would expect nothing from 4K. Yeah, okay. It's nothing. I'll save it as not heard. I keep testing 6K and keep going to test 6K and 8K first because I don't think there will be any response. Yeah, okay. Now we go back to test 3K. Apparently there's more than 20 dB gap. Oh, there's nothing. 3K as well. Okay, then. Okay, then there's nothing. By the way, on audiogram, you do not join the not heard threshold because that's not actually a threshold, so you don't join them. Just saying. Let's move on to 500 hertz. Should be way better. I'll start with 40. 50 is our first ascending. You know, second ascending, save it. And we don't have to retest 1K again. We only test the 1K of the first test year to make sure that the patient is on the same page as we do. Okay, that's our second ascending. Okay, so we finished the AC threshold for both the year already. And then now, as I said before in the last video, for the sake of exam, you will probably just test BC first. Why? Because it's so easy to switch between the different transducers. Whereas in real life, if you want to test BC, it's fine, but you have to take off the headphone, put on the BC conductor, do BC, and come back to take the BC conductor off and put on the headphone to do the masking. That would be such a hassle. So what I would do in real life, I will probably just check out if there's any, you know, over 40 dB interaural difference, and then mask the AC first, you know, just to save some time. We do actually here, we have 45 gap, 45 dB gap, and 45 dB gap, and another 50 dB gap, and 45 dB gap. So it looks like a shadow curve to me. Shadow curve is like the thresholds of the two ears have similar pattern, and the gap is around 40, 45, even 50. And that means there is a over or crossover or overhearing from another ear. So we have to do the masking, and the IA for headphone is 40. So that's why the gap is normally around 40 or 45 or 50. Anyway, we have to do masking. And the mask ear is, so the test ear is the left ear, so the masker should be coming from the right ear. Oh, okay. We start with 1K. So the masker should be 10 dB louder than the non-test ear AC threshold, and the signal should start with the unmasked AC of the test ear. So don't forget to turn on the masker, which is on the right ear. You click on that, so the masker is on all the time. And before that, you might want to, not like you might want, you have to instruct the patient that there will be a noise from the right ear in this case, and it sounds more like water, or I don't know, like white noise, or like when the TV is not working, like that. And ignore the sound, just concentrate or focus on your left ear, only respond to the, you know, the pure tone signal. They will understand, most of them. Sometimes you have to take the headphone off and re-instruct the patient to make sure they know what he's supposed to do. Anyway, let's get started. Okay. As our first dB plateau, there's nothing. We have to increase the signal level. Okay. Response. No, there's nothing. As first 10 dB plateau, second 10 dB plateau. Now, the most important thing to do is pray. Please respond. There you go. Okay, cool. So we have the max AC threshold for the left ear at 1K. We move on to 2K. Well, actually, I'll have to do 1.5K. So we turn on the masker. Start. Wait, what's going on? Oh yeah, a couple levels. Turn on the masker. It should be worse than 90 dB, I guess. Yep. So first ascent at first 10 dB plateau, second 10 dB plateau. You see I'm increasing the masking level to just that line here. 10 dB plateau, which is 30 dB plateau. Now we save it and we turn off the mask noise when we before we switch to the next frequency. Okay, turn off masker. I doubt we'll have any result here. Don't know. Okay. Oh, we actually do. Please, please, please respond. There you go. And we click on save and turn off the masker. Okay, so we finished 1.5, and 2K. We move back to 500 Hertz. This one should be easy. Turn on the masker. Give the signal. Okay. I try the first 10 dB plateau. Shouldn't, yeah, no, there's nothing. First 10 dB plateau, nothing. We increase the signal level. Okay. That's about it, I think. Ooh, okay, it's going down more. Okay. 10, first 10 dB plateau, nothing. We keep increasing the signal level. First 10 dB plateau, second 10 dB plateau. Please respond. Oh, okay. So there's nothing. We go back to 25 dB plateau. Still nothing. Oh, there's something. Okay. And we do 30 dB plateau, please? Yes. Okay. So by the way, if there's no 30 dB plateau, but there's only 25 dB plateau, it's fine. We still accept that. But make sure you have to write a note in terms of your case, not case history, but like your report, your GP report, or general. I can't remember the name of it. Like the clinic report, not like clinic report, but anyway, clinic notes. Yes, clinic note. Okay. Now we turn off the masker. We go back to 250 Hertz and do the same thing. It'll be way worse than that. We're just doing it according to the what the textbook says. Ooh, okay. There you go. Nice. And we turn off the masker. Now we've had the masked AC threshold for the left ear. Cool. Now we move on to BC. So we don't have to, switch back and forth of the different transducers. We just do BC. BC we're testing the right ear because apparently the right ear is the better ear. We always do the BC for the right ear, not like the right ear, the better ear. I'll start with threshold because BC technically or theoretically should be no worse than the AC threshold. I'll probably just start with the AC threshold just to save some time. Was that first or second ascending? I can't remember. Oh my. Okay. We'll just do it quickly. Actually, that's like the basic technique you should be familiar with already. Okay, so the maximum output for 3K is 60 dB. And there's no response. I'll try to extend the range. No, it's not working. So I just mark it as not heard. At least not heard at 60 dB. But and look at the AC threshold here. There's no way it's purely conductive because the loss is so great. So I will still and judging from other frequencies, it's still sensory neural hearing loss for sure. And we move on to 4K, and the maximum output level for 4K is still 60 dB. I mark it as not heard. Move back to 500 hertz. Also, by the way, if you start with the threshold, there might be a chance that it's the sound is so soft that the patient might think there's no sound, even though there might be a sound. So you want to start like to give it a much louder signal than the actual threshold, just to just I don't know how to say that, but just make sure he knows that what's the sound of the signal. So there wasn't a response at the first time, and then now there is a response at the threshold, the AC threshold. Okay, we're doing test 250. Okay, so we've finished the LMAS BC threshold, and it's reasonable to say that the LMAS BC threshold is from the right ear. So now, because this over 15 dB gap of the airborne gap for the left ear, so we have to mask the left ear to make sure we will have the real threshold or real BC threshold for the left ear. Now, because we're testing the left ear, so the masker is going to the right ear. So what I do is what I call 10-10. So for the masker, it's 10 dB louder than the non-test ear AC threshold, and for the signal is 10 dB louder than the unmasked BC threshold. So that's what I call 10-10. And then you turn on the masker because you're masking the left ear, so the masker should be going into the right ear. Now, first thing for BC masking, you need to reestablish the threshold because of the occlusion effect. I'm not going to explain the occlusion effect and why we have to reestablish the threshold, but I'm sure your teachers will let you know. Why I didn't do that is because I've completely forgotten why they are related. But yeah, just reestablish the threshold. All right, and I doubt the BC will be like that good. Anyway, we'll keep going. So the masker symbol now is not like a flat line, it's more like the wavy sound wave thing. Now we've reached the maximum output level, the BC. I'll save it as not heard. It's not, there's another option called cannot be properly masked. It's not cannot be properly masked. We can, it's just, it's too loud. If it's louder than that, it'll become vibrotactile. That means the patient will feel the vibration of the bone conductor before he actually hears the sound. So we don't want that to happen. So it's not cannot be properly masked. Cannot be properly masked normally will be used when there's a risk of overmasking, which is not the case here. So we turn off the masker. We move on to, we actually go to 1.5K, but I doubt there will be any result. Same thing, we establish the threshold. Okay. Make sure you give the signal that has a duration of 1 to 2 seconds. Yeah, I've reached the maximum output level. I'll still save it as not heard. And turn off the masker. We move on to, now we don't have to even move on to 4K because there's basically nothing here. It's dead. So we go to 500 Hertz. Turn on the masker. We reestablish the threshold. First ascending. Second ascending. You say, oh, why did I save that? Oh my God, never mind, I'll just override it anyway. Keep increasing the signal level. And we've reached the maximum output level. I'll save it as not heard. Actually, yeah. Okay, yeah, cool. Turn it off. It's not heard, and we don't have to mask 250 anyway because we didn't do BC. I think we've finished everything here. So yeah, the left ear is the worst ear, but the right ear is no good anyway. If we have to interpret the result, the right ear has a mild to profound sensorineural hearing loss above 1K, and the left ear has a severe to profound. Is it severe though? 45, 60, mild, moderate, severe. Yeah, severe, profound. Yeah, okay, severe to profound sensory neural hearing loss in the left ear. Okay, now we're finished. Whatever, I'm not typing. Describe in simple terms how you would explain the hearing impairment to the test subject. Sure. Okay. Now we move to the test. Wait, what? What's going on? Okay. Yeah, that's the result page. And as always, the faded lines are the, I don't know, like the answers for this test, and the solid blue and red lines are our result. I would say they are pretty close to the final result. And have we made any errors? Frequency testing more than once. Screw you. Test as many times as one. Wrong frequency. What do you mean wrong frequency? An Alma species rate 1.500 hertz testing instead of 2000 hertz. What? Yeah, just ignore that. All right. Otis doesn't know what he's talking about. Not yet completed. What do you want me to do? Testing the BC left with masking is not yet complete. What do you even mean? What does that even mean? Anyway, let's jump to accuracy. Yeah, it's accurate. It's accurate. That's all I care about. Okay. Yeah. As I said, the more text you have, the more precise the test result is. It's 8 out of 10. It's awesome. All right. I have done 10 out of 10, but I don't know. It's too much pressure from the Zoom meeting or from the YouTube recording. But yeah, I'm pretty satisfied with the result, and that the result like that will carry you through the Otis exam easy, right? Easy. The total measure time is the reference time is 14 minutes, whatever. Because I've been explaining every step I was doing. So yeah, okay. So that means we have done a good job. I have done a good job. Anyway, thank you for your time. Thank you for watching, and stay safe. I'll upload this video and I'll make another one. And all right, I'll see you guys in the next one. Bye-bye.